detection, and prevention. So this initiative will address one of the most pressing need in the today's time, and that is obesity. Through this series, we aim to build awareness, translate evidence into the practical clinical strategy, which will work in our Indian metros, in our Indian cities, and in the Indian towns. So that is the focus of this webinar series. And we are delighted to have all of you for our for today's inaugural session. And it is true honor to commence the series with a very distinguished speaker, Dr. Arundhati Das Gupta, who will be sharing her insights on obesity in India, understanding the unique landscape. Can we have the next slide? So this session will include a 30-minute talk, which will be followed by a 20-minute interactive Q&A. So I encourage all of you to post your questions in the chat box, which will be addressed during the dedicated Q&A segment. So with this, it is my privilege to introduce and invite our esteemed faculty, Dr. Arundhati Das Gupta. So can we have next slide? So ma'am is director and consultant endocrinologist at Rudraksh Super Speciality Care, Siliguri. She has multiple awards and recognition to her credit. A.V. Gandhi Award 2010 for the best thesis, Diabetes Awareness Initiative Award 2018, Young Achiever Award, NCCD 2022, ASI President's Appreciation Award 2022, RSSDI Innovation Award, Icon of Endocrinology Award very recently in 2024, Outstanding Community Service Award in 2024. She is also the course coordinator for several national and regional training programs, multiple presentation at various national and international forums, and several national and international publications. So it's truly honor to have ma'am for this inaugural session on how obesity is different in the Indian context as compared to the Western population, as that will set the right tone for the upcoming sessions. Over to you, ma'am. We can stop sharing the screen, support team.
Thank you so much. And it's an absolute honor to be here in this program. And I must acknowledge that this is a great job that Intes is doing, talking about what needs to be spoken about so strongly now. So just give me 2 minutes to share my slides. Yeah.
Yes.
Right. So today we'll be talking about and trying to understand about obesity in India. And, how are we different? Where are we placed? What can we do? What is the, path ahead? That is what we'll try to understand in the next 30 minutes. If we look at what has been shown in the prevalence studies that have come out, you can see the prevalence of overweight or obesity in India, in the world in 2025, and we look at the World Obesity Atlas, and we're trying to look at what is happening, across the world. And then you can see that 40% of the adults are living with high BMI, but in 2025, and 13% of adults are living with obesity. So you can see the numbers are huge. If we look at some of the statistical data that has even come up in the newspapers, this is the Times of India in February 2025, and they said that nearly 50% of the adults in India, they do not engage in sufficient physical activity, and 60% of women fail to meet the recommended goals. And economically, the obesity per se, if we study everything else, is projected to grow to 3.6% of the GDP. That is what what it is going to take out in terms of the economy on an average by 2060. And unlike some countries, and that's the catch there, that we do not have a cohesive national program about this escalating obesity crisis. We've had the ICMR India data, and we've looked at the diabetes and the other metabolic non-communicable diseases. And when we look at where does obesity stand, look at the figures: generalized obesity and abdominal obesity, huge numbers there, 254 in millions, and 351 million with abdominal obesity. So when we talk of our country today, Remember, it was traditionally an undernutrition country. And from where we have gone, from there we've come across to the point where we are talking about these numbers in terms of generalized obesity and abdominal obesity. So if we try to understand that what was traditionally an undernutrition country, why has it gone into obesity? And we take a look at the numbers. Now, if you look at the National Family Health Surveys, that has shown that underweight has reduced from 36 to 19%, which is very good, and in women, and 28 to 16% in men. But at the same time, the prevalence of obesity and overweight has gone up from 11% to 24%. This is 2021 data. It's gone up even further actually now, and from 12% to 23% amongst Indian men, and the other figure was for the women. Amongst a lot of other things that have actually played a role in this evolving, changing scenario about obesity, one thing is the changing Indian diet. And we can talk about a lot regarding the Indian change, the change in our diet, what even we as children, what we had and what we are eating today, what is our next generation eating, how has there been a radical change in the way we are looking at our plate today, and the way we are eating our food. One important area of concern is the packaged food market. You can see there how the Indian packaged food market has shot up exponentially from where it was in 2019 and where it is projected to go up to 2013. That's a huge, huge projection. And this was a study in 2021 that said that amongst children 9 to 14 years, 53% consume packaged food or packaged sweetened beverages at least once a day. So these are really, really worrisome figures. We need to worry about it. We need to think about it, and we need to do something about it. Now, if we talk about genetics, if we look at the genetic loci being associated with obesity in the Indian population, that's not really, really widespread. We have a few novel ones identified, but the trends indicate that whereas, per se, we might not be more genetically susceptible to obesity than other populations, we have definite genetic traits that make us, more susceptible to cardiometabolic complication. That's something we are going to discuss also. And which is why the Endocrine Society of India does not advocate testing, for genetics in every patient with obesity, excepting for a selected few, particularly in children or, with history of hyperphagia or developmental delay or macrocephaly. These are the associations which would prompt you to do a genetic testing. But otherwise, though we understand that we are behaving different genetically for a lot of other reasons, and one of this is this, that because when we talk about obesity in India, it's actually a little difficult to understand because there might be a prevalence of obesity without us understanding, because now we know that BMI is just not enough for identifying individuals at an increased risk of health consequences, because it's not measuring the amount of fat. It is not establishing the distribution of fat. It cannot determine when the excess fat is becoming a health problem. So while BMI is used, it is an easier method to use across for evaluation of the nutritional status. It's just not enough. So underweight, we know, less than 18.5, 18.5 to 25, 25 to 29 and above. But when you try to understand about the limitations of BMI-based diagnosis, now say, look at this. This is a BMI of 28.2. The diagnosis is overweight. The patient has excess body fat, does not have any signs and symptoms, no problems. So here, though the BMI is 28, there'll be an underdiagnosis of obesity, right? And whereas look at another category, here the BMI is 30. But the person does not have an excess of body fat. We do see these individuals. So, and he or she does not have any symptoms. Again, here there is an overdiagnosis of obesity. Another patient with a BMI of 36, oh, yeah, there is excess fat. Yes, the BMI says obesity. Still no signs and symptoms. But this is a person with obesity with preserved health. While a person, with the previous features and signs and symptoms is going to be a patient of obesity with ongoing illness. And this was a paper which came out in Lancet in 2025, and where they strongly projected about the limitations of the BMI-based diagnosis, thereby strongly advocating that we go forward, from what was only BMI based to something else. Now, if we look at the cause specific mortality and BMI, and you look at the other areas like the systolic blood pressure and mortality, this was one study which was done in India, which is actually the largest study that has been done so far in terms of BMI and mortality. What this showed was that BMI was actually less associated with vascular mortality, though it was directly associated with systolic blood pressure. So there are some close correlates of below average BMI, which must have had an important, action or effect on the adverse effects, which could be relevant for all population. Now, when we talk about our genetics, and we talk about how the evolution of fat storage has been, we do know that this is the story of fat storage across the world. But when we look at South Asians, then we realize that probably this fat storage took a different picture amongst this cohort of individuals in the South Asian than what it did in the West. And which is why once we understood the YY paradox, and that was a very, very significant, paper in our understanding from how we are so strongly different from our Western counterparts. We do know this. This is Dr. Yagnik and his Western friend, colleague, who both of whom had a BMI of 22.3. But when we looked at the body fat analysis, whereas the Western doctor had a percentage of 9.1, Dr. Yagnik had a body fat percentage of 21.2. So what was apparent externally was so very deceiving, and was actually, not showing so much of what was happening inside, what is happening inside. So this important paper, the YY paradox, theory that was put forward, completely changed our attitude about looking at obesity based only on BMI. So we now know that we are a different phenotype. We have a lower BMI. We are the thin fat Indians. We have more of insulin resistance, hyperinsulinemia. We have lower levels of adiponectin. Then we have a characteristic dyslipidemia where we have high levels of small dense LDL, high triglyceride, low HDL, and we are more susceptible to type 2 diabetes and coronary artery disease. So central obesity is a major marker of the Asian Indian phenotype. And when we want to measure central obesity, there are various markers. We can look at the waist circumference or the waist hip ratio. We can look at the visceral fat mass, if you have the means to do that, or the posterior subcutaneous abdominal fat. Waist circumference, a very underutilized marker, I would say, which definitely tells us about the excessive fat accumulation in the different depots that can have a very significant implication of disease risk. And it is used, and it is recommended to be used to assess the fat distribution. And we can look at the waist to hip ratio, where the waist circumference is divided by the height. And these have been actually proposed as improved estimations of relative abdominal fat. So here, the relative distribution of fat to the visceral or the intra-abdominal compartment is, we know, we are very strongly associated with insulin resistance and a dysregulated environment of the adipokines, with inflammation, all of which leads to the pathogenesis of so many cardiometabolic diseases. So when you're looking at the waist circumference, it's complementary to the BMI, and it is helping you assess about the cardiometabolic disease risk. So essentially today, waist circumference, it's so simple to get it done, just above the anterior superior iliac span. We do know that just horizontal to the floor. And it will give you an idea, because it has been found to be strongly predictive of the metabolic syndrome, type 2 diabetes, CVD risk, CVD events, and in a number of cross-sectional studies and prospective studies, which have looked at these individual parameters, even stronger than BMI, and which applies even for lean individuals with a BMI of less than 25, who would otherwise not be categorized into the obese category. So waist hip ratio, again, a strong measure of the body fat distribution, and it can be used, for assessing the health risk. It's a good anthropometric measurement. So we can see here that preclinical obesity, when people have tissue, visceral obesity, they would have no evidence, and they are generally at a higher risk of developing disease. And we'll look into it because this category of obesity has also now been classified differently. And then as you go on to chronic obesity, we know that it is a disease which will again affect multiple organs, causing their dysfunction across the body. Various organs will be affected in a clinical metabolic profile. The cardiometabolic profile will be altered. So, trying to understand more about the significance of preclinical obesity and its identification with the help of these parameters. So, this is the traditional measurement of obesity versus the new diagnostic method. This is again the study that I was quoting, which came out in the Lancet in 2025. There, they are looking at various types of obesity. You're talking about 23.7 BMI, no body fat, no obesity. But 28 BMI, no body fat, old diagnosis would have said overweight, new diagnosis says no obesity. So this is again an idea that has been put forward in this particular study. Now, if we look at India-centric BMI classification per se, now we do know that the BMI of 20 to 25 does not fit in with our phenotype. So we characteristically would say underweight is less than 18.5, 18.5 to 22.9 is normal, 23 to 25 is overweight, and anything beyond 25 you would categorize as 1, 2, and 3. So this is the ESI clinical practice guidelines, where they spoke about the BMI more than 23 for overweight, more than 25 for obesity, waist circumference 90 and 80 for men and women respectively, waist hip ratio 0.9 and zero point 0.8, again men and women respectively, and the body fat percentage assessment by the DEXA, more than 25% in men and more than 30% in women is what has been advocated by the ESI. Very interestingly, another paper came out about the wrist circumference, cutoff being 60.5 and 15.7, and the neck circumference also as important parameters for assessing obesity in the Indian setting. This latest paper, which spoke about the revised definition of obesity in Asian Indians. So here they said that you have stage 1 obesity, where you have a BMI of more than 23, and whether you're looking at the other parameters, but no symptoms suggestive of limitations of day-to-day activities due to obesity, no obesity-related comorbid disease. That's stage 1. And stage 2, they're saying, is more than 23, mind you, and plus one of these increased waist circumference or waist hip ratio, plus obesity associated limitation day-to-day activities, or obesity associated comorbid disease. Now, looking at the obesity phenotypes in India, a very interesting development there in our understanding of the different phenotypes associated with obesity in India. Firstly, the ICMR India said very strongly that it is talking about obesity, there's a very high prevalence of metabolic obesity across individuals in the urban and rural areas, where they looked at data from 31 states. And now what is being said is that when you're talking about obesity, you can identify 4 distinct subgroups. One is the metabolically healthy non-obese, perfect. The other is metabolically healthy obese. They're obese, but they're metabolically healthy. The third is metabolically obese, but they are non-obese as per the BMI. And fourth is metabolically obese. So the mono and the MOO categories are also what are being, identified. Metabolically obese, we always knew. But metabolically healthy, non-obese, metabolically healthy, obese, and the mono category coming out very strongly. Now, when we look at the different types of obesity in the Asian Indian population, we know that, metabolically obese, non-obese was actually most prevalent, that is 43.3% out of the 4 subgroups, and also it was more prevalent in the rural areas as compared to the urban areas. You can see there. And when you looked at the anthropometric and the metabolic characteristics of the study groups, they saw that the metabolically healthy non-obese, that was the healthy reference group, compared to that, all the other groups, as expected, had, excepting for the metabolically healthy obese, had significantly higher BMI, waist circumference, diastolic, systolic BP, fasting blood glucose, and LDL-C. Now, as expected, the last category had the highest values of all these parameters. And while physical inactivity and family history of diabetes were higher in the obese, smoking rates were actually higher in the non-obese. That is the metabolic obese, non-obese population. They did see, smoking rates to be significantly high. And as the age increases, the prevalence of metabolically healthy, non-obese, and metabolically healthy obese decreases, and that of metabolically obese non-obese increases. So that is what we need to understand as we're aging. This is what is the chances of this. While we are assuming that we are non-obese and we are perfectly all right, internally the cardiometabolic milieu is changing, and we are basically going to be at a higher risk of these cardiometabolic complications. So the coronary artery disease, you can see even the metabolically obese, non-obese with a odds ratio 1.77, that was significant. And chronic kidney disease also was much higher in this subcategory. So in conclusion, they have said that this unique phenotype, the metabolically obese but apparently non-obese, they are a significant part of the public health challenge that we face today in India, because they constitute more than 43% of the adult population. So identifying these patients during various health checkups will help initiate suitable interventions. Now, obesity and the burden of comorbidities. Now, generally, people who are obese are aware that they have to get their blood sugar checked, they have to get their BP checked, they will need a cardiac check. But somebody who's non-obese and thinks that, I have a very good BMI, why would I be a diabetic, right? We know today that, we have had multiple studies which have shown, characteristically pointed that, in Indians, type 2 diabetes develops at a much lower BMI. There's also a study which was done in England, and they looked at the ethnicity-specific BMI cutoffs. And for obesity-based diabetes, and they did say that the BMI cutoff for diabetes in the Indian population was 24.3. If you look at ASCVD, we have known all along that South Asians develop ASCVD at a younger age and at a lower BMI. So recent data, South Asian Americans are predisposed to abdominal obesity and have a higher distribution of visceral fat. And when they looked at the risk of cardiometabolic risk was higher. Indians also develop CKD at a lower BMI and at a younger age. So you can see all these areas of the cardio-renal metabolic complications developing at much lower BMIs and also at a younger age. So this was the ICKD study, and this was the first study and the only study till date to provide a comprehensive description of a nationwide cohort of patients with mild to moderate CKD from a country like India. And they said that in our country, the cohort is much younger by 5 to 20 years. As you can see, that gap of 20 years from the Western cohorts, and the average BMI is much lower than that reported in the Western cohorts. Also, characteristically, the MSALD. When we talk about obesity and MSALD, it's always double trouble indeed. And this is data from a clinical pathological profile from patients with MSALD with South Asia, and you can see there that 10% were lean, 16.2% were overweight, and 72.7% were obese. So this is the data there. And when we look at the ESI practice guidelines, when they talk about the evaluation, it's an extensive guideline that was given in 2022 for the evaluation and the management of obesity in India. So here they have characteristically mentioned these are our BMI cutoffs. When will you start therapy? From the very beginning. But what will you start in your therapy? Whenever you're crossing a BMI of 23, the diet, the exercise, the behavioral therapy needs to come in. But once you're crossing a BMI of 25, then you can talk of pharmacotherapy, grade 1, grade 2, and then you could go ahead. And bariatric surgery, you can see there from 30 to 35 if comorbidities, and more than 37 with or without comorbidities. When we're looking at weight loss targets, this is again data from the ESI guideline. They have said that, okay, if you manage to lose 5% to 15%, you will have some benefit in type 2 diabetes. Not some, in fact, significant benefit. 7 to 10% benefit in metabolic syndrome, prevention of diabetes, reversal of diabetes has also been seen with the previous category. MSALD, 7 to 10%, where distinct reduction in intrahepatocyte fat and NASH has been seen. PCOS, 5 to 15%, dyslipidemia, 5 to 15%, hypertension, 5 to 15%, and sleep apnea, 7 to 11%. What would you need to assess? You would definitely need to look at the metabolic comorbidities, mechanical impact, a lot of time, overlooked, sleep apnea, osteoarthritis, venous stasis, bladder incontinence. These are also very, very important areas that cause a lot of inconvenience to the patients that need to be looked into. And very importantly, the psychological impact, because a lot of people are battling with obesity, with overweight, but they do not express it, but they go into depression. They are kind of stigmatized. There is a lot of body shaming that is involved, and that leads on to a lot of disorders, psychiatric disorders also. Conversely, a lot of psychiatric disorders, because of various associations, because of medications, because of various other things, are associated with obesity. So that needs to be done, and this is the proposed set of investigations that need to be done for an obese individual before you are deciding on, looking at what action you want to take. So it's glucose, HbA1c, creatinine, lipid, TSH. If required, the assessment of the cortisol axis, liver function test, electrolytes, uric acid, and ECG, X-ray, DEXA if you can do it, ultrasound, and sleep apnea assessment. And if diabetic, then all the other. Very importantly, today we will, when we are assessing a patient of diabetes, of obesity, we there are various staging systems, and one of them is the Edmonton. And I personally like this a lot, because this takes into care a lot of areas. So you're talking about whether you have risk factors, whether the patient has physical symptoms, whether the patient has psychiatric involvement, or it has concerns there, functional limitations, and or impairment of well-being. And when you're deciding on treating a patient, you take into account all of this. So, for example, a patient might be obese, might have a lot of risk factors, but might not have any of the physical symptoms, and might not be, disturbed also mentally, and with no limitations. So, there, your level of prevention will be no intervention. But once you start off with the risk factors and the others come in, then you would go for primary or secondary or tertiary intervention as the need might be. When you talk about intervention, medical nutrition therapy, of course, first try to understand the current practices. It has to be very, very patient centric. Remember, we are live in a country where nothing, no size will fit everybody, because we have such different eating patterns, we have such different choices. The time of sleep, the time of getting up, what do you like to eat, what does your plate consist, what are your festivals. Everything is so different as you go across the country, so you cannot definitely have one medical nutrition therapy plate for everybody. But in general, these are the nutrient distribution patterns that are advocated, that carbohydrate should be 50 to 60%, and if protein, adequate protein should be there, fats should be 20 to 25%, micronutrients should be adequate. Cannot go into the details there. And of course, physical activity needs to be incorporated. Again, this is a slide from the ESI recommendations, that not only are you looking at reduction in the weight, we are also talking about preservation of fat-free mass and maintenance of the weight, and of course cardiorespiratory fitness. So there are a lot of advocacies there. Most of us, we know it: aerobic physical activity at least 30 to 60 minutes per day. And along with that, you would talk about resistance exercise. If you cannot go ahead for 30 minutes of exercise, remember, you can accumulate it through the day in blocks, like 10 minutes, and then 10 minutes in the morning, maybe 10 minutes in the afternoon, 10 minutes in the evening. And even work related activity should be encouraged whenever possible. Now, these are sentences that we've been hearing, we've been talking about, but how much of it is implemented actually on a large scale is something that we really need to talk about. Because had it been implemented, then why are the levels going high every day, in terms of whether it's the BMI we're talking about, whether it's a cardiometabolic complication we're talking about, all of which is going high. So we really, really need to advocate these and talk about it, spread the awareness, and keep talking about it till it is ingrained in the minds as to how you need to take care of the therapies. Now, pharmacological therapy today, we are lucky to be in an era where we have a lot of molecules, not a lot, two molecules basically at our disposal. We have good data with semaglutide, in terms of, you've seen across the study, in terms of weight management. And in the select trial, we've seen about the data with the obesity and ASCVD, and how the primary outcome was reduced by 20% with the use of semaglutide. Very, very encouraging data there in terms of the various risk reductions, the CVD early deaths and heart failure and the kidney endpoints and all of this. So weight loss causing this, and these are, as also the other aspects of the use of semaglutide. So that we've seen the SOUL trial again giving us a very good data in terms of statistically significant and superior reduction of MACE. And then when we are looking at trials across in the Asian population per se, there have been placebo-controlled trials in various sites. This is in South Korea and Thailand, which has again shown us good results with semaglutide. This is a reduction. This is again the reduction. And we've also seen data with tirzepatide, the SURMOUNT data, where we've seen, 16% reduction in the body weight and a 22% an average reduction with 15 milligram. And then we've seen, people who are achieving more than 10% weight loss, being significantly high there. And yeah, sorry, this is not moving. Okay, the slide is not moving for some reason. Just give me 2 minutes, please. Yeah. We'll go across to the next slide. Okay. Yeah. Then again, so this is the improvement in the body composition and in the improvement in the cardiometabolic parameters at 72 weeks. So very, very encouraging data. They're both with semaglutide and with tirzepatide in terms of people, who can, who deserve pharmacological therapy and who can afford this as of now. So results have been very, very encouraging, and good that today we are practicing in an era where we can roll this out to our patients. Have Indian patients been tried with these data? Yes. Both these molecules have actually had trials, or whether you're talking about the select or you're talking about the someone, they have had contributions from the Indian population as well. Ultimately, if nothing works, you will go towards bariatric surgery, but a great number of people are actually shifting from the bariatric surgery segment to the pharmacological segment. These are the indications. I'm not going into the details for these indications for bariatric surgery. So I think we're just about it. We've just crossed at 30 minutes. I'll just wind it up with the summary, saying that, we as doctors, we need to identify that obesity is a disease. Just like diabetes, just like hypertension, just like dyslipidemia, we tend to be a little lax, don't we? Because when we tell our patients about sugar control, when we tell them about lipid control, when we tell them about BP control, we are very, very strict. We tell them that no, this has to be there. But when we're talking about body weight, there'll be a smile on their face, there'll be a smile on our face, and we'll be a little lax when you're talking about obesity. But this cannot go on, because we know the basic roots from which the entire metabolism is rising. So identifying it as a disease and talking about it as a disease is very, very important. In India, the rising prevalence, because of various factors, economy, social landscape, transition and lifestyle, and because of our unique phenotype, because of which a lot of people will not even realize what's happening inside the thin fat phenotype, our food, our high carbohydrate, our low protein, availability, affordability, approval status of various anti-obesity drugs in India. Of course, they've become better now. And the association with the non-communicable diseases, which is at a much lower BMI, earlier age, the psychological distress and the huge burden of psychological distress, and reduced productivity. So importantly, we need to realize that it's just not enough to look at BMI. Please start looking at the waist circumference, the waist hip ratio, or the waist to height ratio. These can be done, but at least the waist circumference, waist hip ratio is no big deal. You can do it in your, it's just a matter of habit of getting into practice in your OPDs regularly, getting your, nursing staff or the people who are helping you out to do it, so that we have definite data. It is not possible to do a DEXA for everybody, but yeah, if you have access to data, I mean, you can do it then very well. So again and again, emphasizing that obesity in India is a silent epidemic. It's driven by a lot of factors: genetics, culture, rapid modernization, but its impact goes way, way beyond individual health, straining our healthcare system and strongly the economy. So today we need a comprehensive India-specific strategy which combines awareness at every level, at the physician level, at the society level, in the press, in the social media, at every level. prevention. So start early, please. Start when they are children. Do not hand them their packaged food. Do not hand them their sweetened beverages, so that they do not get into the habit of doing this. Early intervention, identifying it, early intervention just before the metabolic complication, the cardiometabolic complications set in, and strong policy measures, that is crucial to tackling this growing crisis. It's and really, I'll say this again, I'm thankful to Indus because they've taken this initiative. Because the if we do not talk about it now, then when will we? So we, all of us, we need to identify this as a very big problem that is coming ahead. It is growing every day silently, and we need to take care right now. So on that note, thank you so much. I'll stop sharing my slide, and I'll hand it back to Dr. Nishant, and we can take the questions from here.
Thank you. Thank you very much, ma'am, for that very comprehensive take on obesity in India. And thank you very much also for highlighting that as an Indian clinician, it's also an opportunity as well as responsibility now to handle this obesity crisis, as we would have more and more options available at our disposal. I would request all the audience, you can start posting your questions in the chat box so we can take all the questions one by one. So, ma'am, with your permission, if we can start with the first question.
Yes, please.
So the first question is, how often should we screen Indian patients with a borderline BMI that is around 23 for diabetes and hypertension?
So I think then once you've identified that this patient has a higher BMI, then you would look at the other parameters. You would look at the family history. You would look at whether there are any risk of any complications. There are no specific guidelines which tell you, unlike as in diabetes and hypertension, we have specific guidelines now. We, till date, we do not have guidelines telling us how often should we check, but at least maybe a safe interval of like 2 to 3 years, unless you're seeing something happening. So 2 to 3 years, at least get the basic metabolic tests done so that we do not miss them. And also across you keep on monitoring whether there is a rise in the BMI or not, whether there's a rise in the waist circumference. That is also important. So once you identify that the patient has a BMI of more than 23, make the patient aware so that you are not in a safe zone. You're gradually entering the unsafe zone. So as you're entering the unsafe zone, these are the things that you would need to monitor, take care, and regularly assess.
Yeah, thank you. Thank you very much, ma'am. Next is the practical question, that in normal clinical setup where we don't have DEXA scan or the other facilities, how can we diagnose patient as obese, and how frequently do actually Indian doctors do waist to height or waist to hip ratio?
So basically, we do not do it a lot. That is the problem. So see, assessing the BMI is no problem. I think all of us look at the height and weight. All of us, we do. So we have been looking at the BMI for so long. Remember, maybe 2 decades back, we didn't look at the BMI. Now every patient we see, we look at the BMI. Similarly, waist circumference is just about getting your nursing staff trained to do this. Once they're trained to do this, if they're assessing the pulse, if they're assessing the BP, they're looking at the height and weight. Just another waist circumference is actually no big deal. So how often do? We do not do it often enough, but we need to do it. Just like we have incorporated a lot of things earlier, we used to not do, when we were students back there 2 decades back, we never did the GFR for every diabetic patient, but now we do the GFR for every diabetic patient. Similarly, if we start changing our practice, at least incorporating waist circumference, it's not possible to do a DEXA for everybody, just not possible. Bioimpedance machines and others also, which look into the body fat analysis, that is also not possible unless you have a specified group of people who are looking into it, or you have obesity clinic, you have a focused approach to it. Now when you are just dealing, say you're a physician, you're dealing with all kinds of patients, it's not possible to do that. At least look at the waist circumference. At least that is going to give you an idea about where things are heading, particularly in our Asia, in our Indian population. That will help you a lot. So BMI and waist circumference put together at least will give you a way forward.
Right, right. Thank you very much, ma'am. Next question is, for obese women with PCOS or infertility, what would you prioritize first? The lifestyle modification, pharmacotherapy, or early referral for assisted reproduction?
Oh, I'll tell you this. I got this question in my DM, and I was at that time, because I was writing this answer. So I was concentrating on all the drugs and this and that. So my external, he was there, and he said that I did write lifestyle, but it was very short. And the long thing was, and he's like, you got it all wrong. You have to get it reversed. The lifestyle It's lifestyle, lifestyle, and lifestyle. So because if you send this patient for assisted reproduction and the patient does not lose weight, is not maintaining a good lifestyle, the chances of that patient conceiving are very less. So, we do know that weight loss has a strong impact on fertility, on IVF results, all of it. So, definitely you're going to talk about weight loss first. If the patient is obese, you'll have to talk about lifestyle changes. And because we did see that in one of the slides that I had shown, that if you can achieve a weight loss of, you say 5 to 7%, 5 to 10%, you're going to the patient might conceive on her own, because the anovulation, the vicious cycle of anovulation and obesity that sets in, that just might recover. So let's not talk about assisted reproduction without talking about lifestyle. Certainly not.
Thank you. Thank you very much, ma'am. Uh, Next question is, would semaglutide provide more weight loss in Indians as compared to Western population given our lower BMI cutoff?
So it's difficult to say that. We'll need some more data, but I think there was a subsection of the study where they looked into the results of semaglutide in the Asian population, and the results were seen to be slightly better as compared to the Western individuals. Now, why is that so? It's not basically because we are starting off with a lower BMI, because it also has to deal with a lot of visceral fat and all that. That is not the reason why that is so. We'll need to understand, but till now, small fractions have given us positive data. Now, as we go on using semaglutide more and more, we'll need to, understand this better. And maybe in a few years' time, we'll be able to answer this question better.
Right. Thank you. Thank you very much, ma'am. Next question is also similar. GI side effect, would it be more for our Indian patient as compared to the Western patient, especially if we initiate these drugs at a lower BMI like 25 as compared to the Western population where they initiated 27 plus?
So there was one of these slides, I think I went across it a little fast, which had actually looked into the side effect profile of the Asian populations in the select study. Now, it was not really seen that the Asian population, where they were started off at an early baby, did have a higher rate of side effects. I think the side effects are very, very individual. Now that we've started using semaglutide and tirzepatide and all these molecules in our practice today, we do realize that it's very individual. Somebody just might not have any side effect, and somebody might have very severe side effects. So I do not think that it's going to be more in our population because of the lower BMI, because even in very obese patients also we see a lot of side effects. So I don't think that is going to be the reason. Yeah.
Right. Thank you. Thank you very much, ma'am. What dietary modification an obese patient has to undertake when on GLP-1 receptor agonist, and what specific exercises you advise when somebody is on GLP-1?
So dietary modification is basically not only for a GLP-1 receptor agonist. You would first go for dietary changes and lifestyle changes. But when the patient is on a GLP-1 receptor agonist, given the fact that we do know that GI side effects might occur, so we would specifically ask the patient to have multiple small feeds, not like a huge, feed at one go and then nothing at all. So that is going to cause a lot of GI side effects. We would also want to keep the fat content of the food lesser so as to decrease the GI side effects. But and sometimes maybe you could just put in a prokinetic. That is what we are doing for the first 2 to 3 weeks till they get used to it. And also, I think do not go, they should not be on any other kind of dietary intervention, say not an intermittent fasting along with this, because then there might be a little bit of problem there, particularly our diabetic patients in whom we are actually seeing a great reduction in the blood sugar levels. Even in the ones who are not losing that amount of weight, blood sugar levels are coming down. So a properly planned, balanced diet should be initiated even before starting a GLP-1 receptor agonist. That was the first question. You had another part of the question, did you?
The exercise
Exercise,
recommendations.
yeah. So while we are aware that of the immense benefit that these groups of drugs are giving us, we are also aware about some amount of loss of lean mass in our body. So when you are initiating a patient on GLP-1, you must also advocate about resistance training exercise, so that the lean mass that is going to be that is some percent. It's not huge, but it is there. So that will take care of the resistance training, will take care of some amount of the lean mass loss that can occur along with the usage of these drugs.
Right. Thank you. Thank you very much, ma'am. Next question is, should we start GLP-1 based on a particular body weight? And if so, then what is that ideal body weight and what are the targets for a given patient? How do you decide that?
So the target, we still do not advocate using GLP-1 in as per the Indian or the Asian cutoff guideline is still as per the Western cutoff guideline. So when you're anybody who has obesity, you can start using in more than 25, you can start using GLP-1 receptor agonists. Now you cannot give a particular target because you cannot say who is going to lose how much. You cannot set a target, but obviously when you're putting in such a molecule you would expect to see some changes. Unless you see those changes, you're not going to continue an expensive molecule like this. Or so, but there is no given target. It's not like if you do not reach this much in this many months, then you should stop. Nothing has been put out as yet. We still do not have any guidelines telling us like that, anything like that. So I think a reasonable amount of expectations. We've seen huge loss. So it's like 20% with 15 milligram, and with semaglutide also huge loss. But then remember, those were at the highest doses. Now, as you go across, as you're increasing the power of your molecule, the percentage of weight loss is going to be higher. So you have to wait. You have to wait and watch a particular patient. I do not think that there will be a particular cutoff ever. You'll have to wait and individualize and understand whether this is good enough for your patient or not.
Right. I think targets are set by more by stock market, and that is why the stock prices crash every time new molecule results are announced.
True.
Uh, do you recommend high protein in patients who are on GLP-1 receptor agonist?
It's not high protein. So there have been a lot of studies. Some have advocated 1 gram per kg body weight. Others have said zero point 0.8. But remember, these are patients are rarely only obese patients, right? So they would be maybe diabetic or hypertensive. They could be having a CKD element. They could be. So when you're deciding on the protein, you would take a look at the lean body mass. You would decide. Now, also remember, sarcopenic obesity is also a strong area of concern. So, what is your patient profile that would help you decide on the amount of protein that you're giving? And yes, because per se, as Indians, our protein intake is less. So, and people in their attempt to cut down on the amount of calories, they also cut down on a lot of proteins, which again has an effect on the lean body mass. So, we need to take care that the protein percentage is not too low, but not too high either, depending on. So that is why it's important that when you're initiating a patient on an anti-obesity treatment, the patient should first meet a qualified dietitian who will be able to explain the things to them. That it is not only about sugar, it's not only about the sweets, it's also about a lot of other things. So from where do the calories come in? They would need to understand. So I would not say a high protein diet, but a moderate protein diet is what is advocated for most.
Right. Thank you very much, ma'am. Next question is how long we should advise patient to take GLP-1 receptor agonist, and what should we do post 1 year if patient stops GLP-1 receptor agonist? And that is what probably we will see in Indian scenario.
Okay. How long we do not know, because we have data for 5 years. We'll say that okay, safely it has been given and you can give it. If patients stop, you even before initiating, they'll ask you what will happen when I stop it. Will the weight come back? So remember, with both the molecules, what has been seen that after the molecule was stopped, there was some amount of weight regain. So, and which was to the tune, if they lost around 15%, they regained around 8 to 9%. So you have to tell them that, but the remaining persisted. So at least that 7%, and 7% is no less actually. So that persisted, provided the patient maintains the lifestyle changes and the diet and does not binge. So remember, even with bariatric surgery, weight tends to come back if they do not maintain the lifestyle changes. So, but you have to accept it and tell your patients that once you stop it, some amount is going to come back, because otherwise they're going to tell you like, I spent that amount of money and the entire weight is coming back. What is the use? What is the use? Also, what you also need to tell them is about the metabolic memory. So if you have lost weight and you've remained in a lower body weight for say this means say for a year or 2 years, whatever, that has a very strong implication on the metabolic memory, and it has an implication on what is going to happen to your heart or your kidney or your liver. So that also needs to be told to them beforehand before initiating these molecules.
Right. Uh, Ma'am, next question is the right now one of the burning topic, the risk of diabetic retinopathy with semaglutide. So in general, does it make sense to titrate more slowly? Say, for example, every 3 months instead of 1 month to reduce this risk in our patient population?
So, because you would firstly be screening, and you would see that the patient does not have retinopathy before initiating. And once you have, I mean, uh, we have not seen data that going slow basically prevents retinopathy. That's not something that we have understood till now. It's not like the increase in the dose is what caused the retinopathy. That is not our understanding till now. So I do
Hmm.
not think going slowly is going to help, but a proper screening and starting it in the correct individual is what is more important. Right, and also telling them about it, that if you face any visual changes, apart from retinopathy, it's also the ischemic optic, neuropathy is also what is being spoken about. That is, so you need to tell your patient that in case you face any such issues, you need to report back immediately.
Thank you, ma'am. Drug interaction that we should know of in GLP-1 receptor agonist with the other diabetes drugs or other like chronic metabolic disorder drugs.
I do not think there are major issues. Please correct me if I'm wrong, Dr. Nishant, because we have seen data with the usage of all the other molecules. But given the fact, supposing you are using it with say metformin at high doses, and the patient already has GI complications with metformin, then you would be expected that levels might increase. But as such, per se, drug interactions with any of the known with the regularly used oral antihyperglycs, I'm not aware of.
Right, ma'am. Next is again the practical titration question. If patients do not have any side effect at 0.25, would you directly move from 0.25 to 1 or will you still follow 0.25 to zero point 0.5 to 1?
Definitely go up in a stepwise manner. From 0.25 to zero point 0.5 to 1 is what has been recommended, and we should go about it. Because remember, all the studies have gone about it in that manner only. So we should not jump the gun. We will need to do it as has been studied and as the results have been seen in this manner only. So I would personally go up to zero point 0.5 and then for 4 weeks and then go up to 1.
Right, thank you, ma'am. Cardiovascular benefit of semaglutide based on your clinical experience.
My clinical experience is too less as of now. It's we've just started using semaglutide, so we do not know. So, and again, cardiovascular benefit, it is difficult as practitioners to say what cardiovascular benefit you're giving. Cardiovascular benefit has to be assessed from studies which are well equipped to understand the cardiovascular benefit. So I think none of us are in a position today to already say talk about the cardiovascular benefit, but we are getting data, which we are assimilating data. We'll have real world data accumulated over the years. We'll understand. But cardiovascular benefit, as has been shown by the studies, because they were meant to look into it, so has been very encouraging till now, certainly.
Right, thank you, ma'am. Next question is about uh, in your view, what would be preferred more by Indian patient, oral semaglutide or injectable semaglutide, especially once the higher dose that is 25 and 50 becomes available, would that be preferred as compared to the injectable semaglutide 2.4?
So I think preference is always towards oral, but when you talk about once weekly thing, that again has a role to play. So you tell them that you're just taking 4 injections a month, and that kind of, some people do prefer to take once weekly injection as compared to daily tablets. But the resistance against injections always remains. So there'll always be a section who will try to prefer taking oral. But I think till now, when we've started using these injectables, semaglutide, the acceptance levels has been fairly good, because particularly once a week kind of appeals to them that okay, fine, only 4 injections a month. So that I think works.
Right. The next question is from Dr. Parveen Gupta. How effective are the recent 2025 obesity diagnostic guideline, especially the new lower BMI threshold and weight circumference criteria in terms of early detection and management with the our routine practice?
So that is what we basically discussed about, that we are taking a paradigm shift. Our understanding of obesity is taking a paradigm shift from only obesity, from only BMI. And I think this is effective because we are talking about preclinical obesity. We are talking about the metabolically obese, non-obese. We're talking about so many different phenotypes of obesity now. So I think yes, it is practical. It is more in keeping with what we are seeing regularly. Just branding every person with a BMI, higher BMI as obese, and otherwise is not the way to be. Particularly now that we've understood so strongly about visceral fat, as we're using the DEXA more frequently, we're understanding, about the visceral fat and how different it is. So having understood that, I think yes, the obesity guidelines are clinically significant, and they are going to play a role in changing the scenario if we start incorporating them in our practice.
Right. Thank you very much, ma'am. What are the common problems right now you are facing with regards to the injectable GLP-1 receptor agonist?
Cost. What is the cost? Certainly, because there will be a lot of people in whom I would want to use, but they are unable to afford it. Otherwise, GI symptom wise, I think I personally till now cross have not had major people have had a little bit here and there, but you have to counsel them beforehand that this is going to happen. So, but I think most of them settle down by two to 3 weeks or so. Apart from that, I have not had. Yes, there were issues about people who were on tirzepatide. They did not. The vials were over, and the pens did not come in, so that gap was there. That was one problem we faced. Other than that, I think all has been good till now. But again, as I said, we've just started using it for a few months now. We'll need to see what's happening.
Yes, ma'am. I think it is about with regards to the injection. So when you inject, so any issue with regards to injecting a drug, any specific concern?
No, none as of now. Until now, no.
Right. The next question is, do you see other drugs in diabetes can be stopped if patients are given this GLP-1 receptor agonist?
Yes, 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 very strongly. As I was saying, that a lot of our patients, some of my patients who were on insulin, multiple doses of insulin, their insulin requirement has come down drastically. So, and that is why when you're initiating these molecules, if your patient is, say, a well-controlled patient, then you should down titrate your molecules definitely, because then otherwise the patient might go into hypoglycemia, because the requirement is definitely coming down. And as I said earlier, also there are patients who are maybe not losing weight to that extent, but their diabetes, their sugar levels are really coming down very, very well. So we are seeing this across. Yes.
Right. The next question is, what is the role of these agents in onco patients, oncology, the cancer patients?
I do not know whether you would want to put in a GLP-1, I mean, this particular agent, unless obesity is a very strong factor there, because oncology patients are generally more cachectic. They're dealing with a lot of other problems. Is obesity a major concern there? I am not very sure. And I personally, I don't think that is one category where I would generally choose, unless somebody has been in the remission phase or is okay, and then is obesity is a major concern. That's a different issue altogether. But oncology patients, the most of them that we see are in the other end of the spectrum, aren't they? So I don't think generally we would be using them in that category.
Right. So I think we can take just one last question. That is from Dr. Bhupinder Singh. In India, many patients with normal BMI also have a sarcopenic obesity. So would you be using these drugs or how to take care in sarcopenic patients?
So sarcopenic obesity is a very difficult thing to deal with, because you are dealing with obesity and then again you're dealing with sarcopenia. Sarcopenic obesity is not somewhere where I would choose to use these molecules, because of my concern with the lean body mass there. Firstly, we mostly do not identify our sarcopenic obesity patients. Yeah, so firstly, we need to identify them. Again, the tests that need to be done are very, very simple. The questionnaires that need to be filled out are very, very simple questionnaires. So if we start identifying more of our sarcopenic obesity patients, we need to look at them in a different way. They need more of resistance training exercises. This is a category where maybe you would need to put in a little bit of protein, provided that there are no contraindications. So sarcopenic obesity, I don't think per se would be my, these molecules would be my first choice in sarcopenic obesity. But yes, I mean, if you think that they would help, you can put them, provided you're giving a supporting, therapy also for the sarcopenia part of it.
Right. So if you can just sneak in one last question, which has just come. In India, maybe adherence will be an issue. So what if they miss a dose or a two? How would you manage then?
So if you miss a dose on a particular day, supposing you were supposed to take it on Saturday, you can take it on Sunday, you can take it on Monday or Tuesday, but not beyond that. So that, because of the half life, so that Otherwise, if you've missed it for 3 4 days, then you skip that dose and you go on to the next dose. But if you skip 2 doses, really, you cannot take 2 doses after that. You will just take 1 dose after that. Like, the last dose that you've missed, they'll take it like within 4 days, but not further than 4 days, because then that's going to interrupt with the half-life of the next dose.
Right. I think just more detail came into the same question. If patient discontinues semaglutide for after using for 3 to 6 months because he had some good weight loss, then once again weight regains in the next 6 months. So probably would you start again from 0.25 or from the last tolerated dose?
So that's a very interesting question. That is also something that I looked into it. I did not get, because I was looking into it for one particular patient actually who had stopped. But I think I will maybe restart at a maybe not at point 0.5, 0.25, but maybe at point 0.5. Not go to the highest, not go to the high dose at a go, because of the GI side effects. Because the GI side again will take some time to come, get in
Mm.
accustomed to it. So therefore, I think I will still go slow when I'm restarting.
Right. Thank you. Thank you very much. So I think we will, with that, I think probably we would like to close the Q&A session. So I would like to express my sincere thanks to Dr. Arunati Das Gupta for that very insightful and impactful session. I'm sure there were many learnings for our Indian patient, how they are different, how to diagnose it properly, and how to utilize those medication in our day-to-day practice. And I think we have received a very overwhelming response. We had around 1180 live audience and close to 6,000 registrations. So that shows that probably the initiative that we have started is something it is going to affect the Indian physicians, and they will be taking the good leverage of this initiative. So I would also thank all the audience who have joined us live for today's session. I think it was a very lively interactive Q&A session, and I hope most of your questions have been answered by our faculty. So with this, we would like to formally conclude the inaugural session of Diabetes Connect Live: No Weight, Awareness, Action, and Prevention. And we hope you find it valuable, and we look forward to welcome you again in our upcoming session in the upcoming months. So until then, thank you once again and wish you all a pleasant evening. And with this, we would like to sign out of today's meeting. Thank you. Thank you all.
Thank you so much. Thank you.
Thank you, ma'am. So studio team, we can now stop the live feed.